Okay. All right, so welcome everybody. Thank you for showing up. As we've said in the past, this is being recorded, so you'll be able to watch this later as well. We're doing a session on advanced care planning tonight. This is always a topic that strikes fear and interest as well into the hearts of any good nurse. So we're just going to run through it as it pertains specifically to aged care, which is what we do. I realise we haven't put in an acknowledgement of country slide, so I'll just acknowledge the traditional owners and custodians of the land on which we're all meeting tonight, wherever that may be. And we pay our respects to elders past, present and emerging, and anyone on this call or watching this video who identifies as one of First Nations people. Thank you. So here we go. Advanced care planning, which includes medical treatment decision maker and advanced care directives. Now, you've all seen these scenarios, I'm sure, and this is partly why you're here. You get these classic cases that we see over and over again. Got a 76-year-old father with disseminated cancer in the ICU on a ventilator with progressive pneumonia, or a 93-year-old mother with dementia from a nursing home in hospital for 6 weeks with a fractured knob. The 84-year-old mother bedbound and unable to speak after a stroke, who is planning to have a peg inserted and be transferred to a residential aged care facility. Or a 62-year-old father with a terminal condition who's requested an NFR and is resuscitated because there was no documentation. And so the common factors there are a choice. Was there poor communication? Did the family make a decision, override what was already talked about? We don't know. So the relevance of advanced care planning to residential aged care is that it gives the staff a clear direction and guidelines on how to proceed. It also reduces conflict amongst the team and prevents unnecessary admissions to hospital. This is always a really strong driver. Nobody wants to see the 96-year-old sitting on a trolley or lying on a trolley for hours and hours on end in a busy ED, probably ending up worse off than they were when they got there. And the desired end result of the program is improved patient care and more choice, greater choice and greater control over how death is managed and control over as death approaches. And as I said, a reduction in unnecessary presentations to emergency departments. This is a massive issue, and it's one of the main drivers of getting the advanced care planning done, because it's really distressing for everybody involved, including the nurses and the family and the person at the centre, the resident, when they end up in an emergency department, as I said, and often lying on a trolley for hours on end. They can easily sustain a pressure injury over that time, and all for nothing. It's just a lot of distress for no good outcome. So what is advanced care planning? I won't read all that. You can see that for yourself, but it's basically about thinking about the kind of conditions that you would find acceptable, the kind of outcomes. It's more about outcomes really than, it's too hard to sort of think, well, if you had a stroke, would you want us to do this? And if you had a heart attack, would you want us to do that? And what level of this or that do you want us to do? It's much better to have the approach of, how do you want to live your life? What's important to you? And what is meaningful existence, and where is your line in the sand? It supports the principle of patient autonomy, which I think is really important, and respects the person at the centre of it all, and their dignity and the treatment choices that they would make. It's definitely an ongoing process. This is really important. You can't just say, well, we've got your advanced care plan. It's 10 years old, but never mind. We always have to be continuously contributing. It's a living document, and it needs to be reviewed regularly, and also in front of mind, say, as aged care nurses, there's many opportunities throughout the interactions with the residents where you could be picking up on either affirmation of what they've already put in an advanced care plan, or something that's a bit contrary. So maybe they made an advanced care plan 3 years ago, or even a year ago, and now they've had a really bad year and things have really changed, but they haven't updated their advanced care plan. And so now they're struggling down the corridor with you, or you're in the shower with them, giving them a wash, and they might say, oh, I've just had this, I can't go on, I don't want to do this anymore. Any kind of comments like that. And that's a great opportunity for documentation of those sort of things. You know, that it's an ongoing conversation that we have with our residents all the time. We should be listening out for it. An advanced care plan does not have to be written down. There's a lot of people who balk at the idea and really struggle with the idea of having a written care plan. And so we shouldn't be forcing people into doing that. It can be just a spoken plan. The most important thing is the conversation that's had around it. It can be a letter, there's the train. It can be just a simple letter about, this is what this is how I've lived my life, and this is what I want. This is what's important to me. And it can be documented in the notes. As long as there's evidence that a discussion's been had, the discussion is really the most important thing. So why is it important? We know that most people will die after a chronic illness and not a sudden event. And yet we keep on expecting, or we never expect these things to happen. You often hear these stories about, 93-year-olds who are saying, oh, I always thought we had more time, or the children of 93-year-olds saying, oh, never expected it. And that's part of the culture we live in, and that this is why advanced care planning is important, because we otherwise don't get a chance to talk about it much. We don't take the opportunity because there's not a lot of open, free conversations, especially amongst families. Everybody's thinking, oh, I don't want to bring it up because that's upsetting. And they're all thinking that, even though everybody wants to talk about it. That's interesting that half of us are not in a position to make our own decisions when we are near death. And that can be because of you're just too ill to think clearly. You could be you may have dementia, you may have a delirium, you may not be able to communicate, say if you've had a stroke or something like that. You might be have some deranged blood work, which means that you're not thinking clearly. Serious illness can really impact your ability to make a considered decision. And so best to talk about these things ahead of time, rather than say, oh, well, when the time comes, I'll make my decision, because you may not have that opportunity. The family there's a significant chance that your family won't know what your views are if you haven't discussed it with them. And it puts everybody in a difficult position, including the doctors. They will often default to the position of treat, unless otherwise instructed to do so. And so, because there's no doctor who wants to make that decision on behalf of a patient. And so if no one's stepping up to say, no, this is what we talked about, we don't want this treatment to continue, then the doctor will just keep on treating. And especially if you present to a larger hospital, if you transfer your elderly resident out of a small facility up to, say, Wangaratta or Albury or Shepparton or Kilmore, you will, they'll get onto the conveyor belt and won't get off until somebody actively gets them off there. And the statistics are that many of us are kept alive under circumstances that are not dignified, and there's lots of suffering involved and treatments that people wouldn't have wanted. A lot of the ED settings are an awful place for people to end up when it's very busy. The staff don't have time to sit here and tell us all about your story, and we'll have a, we'll just you really get to know you before we make decisions about how we treat you. And sometimes those directives are unavailable if they don't go with the patient or the resident or the person, or there's no family there to speak up for them. Again, that's another decision, another reason why we should be having advanced care planning discussions and ACPs in place. Now, there's ethical considerations too. You can probably look up more about this. I encourage you to. I won't go into it too much now, but there's the 4 ethical considerations when making decisions about treatment choices. So you can take a snapshot of that and go and look it up yourself. I encourage you to. As someone who's working in this end of life space, it's a really worthwhile area to look into. Capacity is a tricky one. I think that comes up a lot, particularly in aged care, where you've got people who may have a questionable capacity. You might be wondering whether your resident person is actually able to consent or not. The law says that everyone is considered to have capacity or competence unless there's been sort of a ruling that they're not. So you have to assume competence unless a doctor or someone steps in to say, no, this person does not have capacity. And this is the driver of capacity. So I always thought there was only 4, but obviously 2 of those things generally belong in one thing. But so the person has to have the ability to understand what's being said to them. They have to hang on to that information and be able to give it back to you, to sort of say, now, can you tell me what I've just told you? And they need to be able to reflect that back to you. They have to be able to weigh it up and demonstrate that they understand the implications of the decisions that they're making or the information they've been given. And then to sort of deliver an answer that is coherent. So that's a bit of a process, and it can take a bit of time. So these are, well, they're obviously the levels of care that people can receive. Not too sure what the pyramid was doing there. I suppose, let's see, the intensive's probably the top. No, I don't know. So palliative care is aimed to keep the patient free from pain and discomfort, and contribute also to quality of life, not necessarily length of life. Now that can include treatment or investigations, but only in so much as it contributes to the patient's comfort. Excuse me. So limited treatment can be a bit of palliation plus maybe a trial of some kind of treatment like antibiotics, or, we'll do a CT to find out, how serious this thing is, and then we'll make a decision and say if they appear to have a bowel obstruction. So they might do an abdo X-ray or a CT just to establish, yes, this is what we're dealing with. And then we'll say, okay, well, judging by the advanced care plan for this person, they've opted not to be treated aggressively for that. So we're going to, behave accordingly. We won't go in for surgery. We'll treat it conservatively, and if it doesn't resolve, then we'll deal with that. Active and intensive, I think you all know, you understand what that is all about. So advanced care planning is everyone's responsibility. I can't stress that enough. It's everybody's job. It's not the doctor's job. The doctors don't have time to do advanced care planning with their patients and with the people in aged care facilities. They just don't. You couldn't pay them enough because it's a process, and it takes time. It takes at least a couple of hours to do one advanced care plan properly with somebody, to get a meaningful document or some kind of agreement. So it then becomes the nurse's responsibility. Everybody can contribute, but I think as nurses caring for these people in aged care facilities, you're at the you're on the front line, because it's not an easy thing for people to do. The average layperson can struggle because they often don't understand all the nuances. They see what's on TV, 75% cure rate from CPR, and you can save him, doc. Like we're just sort of so immersed in that that positive story from all the medical dramas that many people don't have the understanding that CPR has a terrible success rate, and the older you get, the worse it gets. If it's unwitnessed, it gets even worse, blah, 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 all those things that I think you all know. And so advanced care planning needs to be done early, and it needs to be revisited and normalised. It has to be normalised. I think that's the hard thing. Everybody shies away from it because we don't want to upset people or make them think about death. But it's not really about death. It's about living well and what living well means to you. And there's nothing wrong with talking about death, because it's the only thing that we can be sure of. And so sometimes we need to be careful that we're not shying away from it because we're uncomfortable with it, because there's a lot of older people who actually feel quite comfortable. They've had time to think about it. They're on the whole, a lot of older people have had the opportunity to ponder their own mortality. And sometimes the nurses are saying, oh, I don't want to upset them, when it's actually we're the ones that are uncomfortable with it. So have a think about that too. I invite you. It's the process of advanced care planning is a conversation. It's definitely a two-way conversation, and we need to share what we know and invite a response and discussion from the person without any judgment and with lots and lots of listening. It's good to, it's almost essential that we include any family or loved ones or significant people in the residents' lives as well, because it's definitely a communal discussion as well. People will make decisions dependent on the people around them. They say, oh, well, you've got to be careful about the ones that say, oh, I don't want to be a burden, so just sort of let me go. And again, it requires skill and a bit of attention for us to actually have an understanding of all the nuances around this process. So introducing the concept, I'm a strong believer in the idea that it should be introduced as soon as the person comes into the facility, because then it can be, that's the opportunity to normalise it. Like, I know it can be, it's a massive change, it's a massive upheaval, and it can be quite a difficult time for a family when they're admitting their loved one into a residential aged care facility. But if you normalise that and say, well, these are one of the things that we usually require, and explain to it why you want it. It's because we want to make sure that we're caring for them the best way possible, and that we're prepared for anything, and that we know you as well as we can, because it can definitely be an opportunity to get to know the person even more, if you put it in those kind of terms. So we need to know all their current medical conditions, their past history, and any kind of experiences they've had with, say, maybe they have had to make decisions for somebody in the past, and so they might have a lot of biases or things, the agenda that they carry with them. It takes a bit of time and attention. These are conversation starters that you could use. Again, this is being recorded, so you can take a snapshot of that if you like. But it's more about, how can we care best for you? What matters to you? What matters most in your life, what makes you, I won't say what makes you get up in the morning, because it's probably the nurse that comes along to drag you out at 7 o'clock. But what gives you joy, and what do you look forward to every day? And then you can sort of add the medical sort of side of it as well. There's a few more. How can we help you live well? So that's a good one, I think, to sort of say, we want the best for you, and we're asking you these questions for your benefit. This is what we want to know all about you and to see you. Yeah. As I said, you can ask them what kind of experience they've had. They may have witnessed, or they may have cared for their parents, or another relative, or witnessed somebody dying, or they may not have. I would be surprised, but by the time they get into a facility, they will have some kind of experience of death, whatever that might be, whether it's siblings and they would have had, their parents have definitely died, I would say. I reckon. And to take that opportunity this is a good opportunity for you to open up in a conversation about this in a non sort of confrontational way. And you want to have these conversations when they're feeling reasonably well, instead of all of a sudden they're sick, they've been into hospital and they come back to you and they go, so, then you get into those conversations, and that's worse. So I think asking anybody these questions and pondering these questions while people are feeling well is really the best thing to do, as I'm sure you can understand. Now, I think this is medical treatment decision maker. I don't know what's happened to this slide. Hang on, let me drink. There you go. Selecting a medical treatment decision maker. Now, this I can't stress highly enough. Really, just take your time, and this is for you guys as well. Like, everybody should have an advanced care plan. If you haven't got one, you should make one. Be very careful about who you put in charge of your future healthcare decisions and possibly life and death decisions. First of all, they have to fill the legal requirements of being over 18 and have the capacity to make the decisions on your behalf. Now, if you don't make a decision, there is a default hierarchy. I think it goes parent, spouse, parent, child, and then the nearest living relative, and so on down the line. But there are caveats to that. You can have, say, if there's an elderly mother who has 3 children, and the son is the oldest, but he lives in America, and there's a daughter living next door, the daughter would be deemed to have, if she is popping in every day, a close and continuing relationship with that parent. So her voice will have stronger sway, even if the mother has put the son in charge, as they often do. Oh yeah, just default to the son because he's a man and they know what they're doing, or he's the oldest, or whatever it is. So while you're counselling people about appointing a medical treatment decision maker and what you know of the family structure and dynamic, just always include that suggestion that they might want to really think carefully about who it is that's making a decision. Are they good at making decisions under pressure? Are they going to follow your wishes? Are they going to honour what you've asked them to do? Are they going to chicken out at the end and say, no, I don't want to make that decision, it's too hard, or I don't want to let her go, or whatever it is. So yeah, it's got to be someone that you can trust to step up and be that person when you need them. I myself, I still keep telling this story. I probably should think about my oldest son eventually. He's nearly 28. But I've had an advanced care plan for probably 10 years, and I have nominated my niece, who's in her early 40s. She's a funeral director. I hope that doesn't mean that she's looking for the work, but I've put her in charge of my medical treatment decisions because I trust her. She's a generation down from me, so that helps because I'm the youngest in my family. So if I nominate any of my siblings, it's possible that they could die before me. And I trust her. She's very calm, and she's very good at. She's got a great business head, and she can make a decision. She's actually also able to step away from that decision making, that emotionality, the way perhaps my children couldn't. And I still see my kids as, my kids, and they're still, in their 20s. And I don't want to put that kind of decision onto them because I myself have some sort of fairly radical ideas when it comes to advanced care planning, and I know I can trust my niece to make those decisions for me because we've talked about it and she understands. So can't stress highly enough how important it is to just, to be careful about who you put in charge. There's a million horror stories out there. I won't go into them because we'll be here all night. I apologise for the small print here. I hope that's not too bad. So the medical treatment decision maker is a legal appointment, and you make that. The doctor can sign off. Your medical officer can sign that off when you're filling out the forms. He or she can make that determination. You don't have to go to a lawyer to appoint your medical treatment decision maker. Now, forgive me if I didn't check this slide. So there's a couple of things that may not be relevant here, given the updated Act. So the medical treatment decision maker can agree to or refuse medical treatment on your behalf. They can't be used to make any decisions on financial, legal or guardianship decisions. It's purely medical decisions that they are in charge of. They can't refuse treatment that alleviates pain and suffering. So they can't refuse palliative care. For what purpose, I can't imagine why you would want to do that, but it's a basic human right, and the decision maker can't refuse that. And I will just make a quick comment that voluntary assisted dying, in case everyone's wondering, voluntary assisted dying does not come under this Act at all, and a medical treatment decision maker cannot make a request for voluntary assisted dying on behalf of anybody else. So that's just, I've said that. I'll just try and bring this down too. Yeah. I'm just reading this slide.
No, VCAT can end up being the whenever people hear VCAT, people tend to recoil a little.
Yes.
But they are a tool that are out there and can be used in instances where it's not quite so straightforward, and they are going to be very ready to tell you if they're not the appropriate person to go to for it.
They will.
I think that might be the take-home message.
Yes, I'm sure many of you have had the situation where you've got a resident that doesn't have an obvious next of kin. There's no one sort of putting their hand up. It could be some distant niece or somebody like that. And so, yes, you can go to VCAT through the Office of the Public Advocate that will sort of take over that person's case. But yeah, they're very reluctant to do so, and they will do anything they can to get out of it, because it's not an ideal situation, but it's possible. It's there if you need it. Okay, so this must be the hierarchy that I was talking about right now, I understand. Okay, yeah, so they're the four legal ones. So apart from all those legal appointments, the natural hierarchy then defaults to the spouse, a primary carer, nearest relative, brother, sister, yep, uncle, aunt, blah, blah, blah. Anyway, I'm not going to cover that. You can find this on, I think this is from the Office of the Public Advocate website. So if you're worried about whether your patient can consent, you can go to there and have a look. So making decisions about future care, discussions should definitely include beliefs, values and goals about life and death, what's important, how they see death, you know, just, and this is why it takes so long, and it's not a doctor's job. Of course, you know, I agree that not many nurses have got the time to do this either. And that's why I would encourage you to agitate to get somebody responsible in your facility for doing advanced care planning, and maybe nominate one day per month for somebody, one of the nurses who's passionate about advanced care planning, to systematically go through and get all of your residents' advanced care plans and keep them up to date. You can include funeral wishes. It's always really helpful to have that somewhere in the documentation about funeral directors and if they want, you know, who they want, because, you know, I'm not too sure. A lot of facilities tend to sort of boot people out as fast as they can, but it's just really nice to not have to turn around just as the person's died and have to ask that question. It's much better to get that ahead of time. And it's also, it's a hard thing for families to worry about at the very end, you know. You know, we never thought about it. And it's sort of like, who do you choose? You open the, well, you used to open the phone book, you go to Google and just pick one, you know. So talks about resuscitation, and again, you need to include that discussion about CPR and the realities of CPR, and what you'll end up with is at least some broken ribs, so a lot of pain, and in recovering from that, you may end up with pneumonia and die anyway. You know, like, you've got to be. I think it's really important to give people realistic information instead of, you know, sugarcoating things and then ending up receiving treatments that they've opted for without, you know, fully understanding what it was going to be like. You know, you don't want them to say, God, if I'd known it was going to be like this, I wouldn't have said yes. Or you watching them, you know, battered and bruised and still dying. We're all good at trying to elicit what's important for these people, but I think for our residents, I think it's really important to stop and listen to them. Sometimes we can overlook them, or, you know, we gathered all that information when you came in, and then we sort of just we forget who they are, and they're still evolving, and they're still becoming who they become. They haven't just stopped living. Ooh, sorry. Beneficial treatments versus burdensome treatments. I think we all understand, and we've seen enough as aged care nurses. We've seen plenty of evidence of treatments that were burdensome, like somebody receiving getting a PICC line for a chronic wound when they've been bedbound for 3 years, and their health status is very poor. But no, we'll put in a PICC line because the doctor wants it, or because the family won't want it. You know, they might get 3 weeks into the treatment and then die from overwhelming infection, or from renal failure because of the IV antibiotics. You know, there's got to be this approach of the older we get, the more perilous these acute treatments become, and just that understanding that you know, none of us can live forever, and how do you want this to go? And this is why planning is so important. The earlier we do this, the better, so that we've had plenty of discussions and we're talking about it all the time. And these burdensome treatments, I think we do need to be realistic, you know, paint a more realistic picture instead of being all airy-fairy. You know, the doctors sometimes won't be really straight with the resident.
But, oh, sorry, Rose, I was just going to say, Burdensome can also look like something as simple as somebody having page upon page of medications on their drug chart, and sometimes maybe getting a pharmacist in to come and rationalize those medications so that they're not unnecessarily taking multiple tablets that they may well be struggling to swallow, perhaps, as well in that stage in their illness or their frailty. So it can be big thing. We often think about big things like peg tubes and IV infusions and stuff, but it could just be something that we come across with everybody, which is just too many pills that we don't need.
Yeah.
So just wanted to put that one out there.
Yes, and even burdensome procedures. You know, if we're still taking a curative approach, then, you know, we get the blood pressure cuff on the arm every 4 hours, and that's awful. Yeah, and or the daily weighs, or the measuring all the ins and outs, and you know, all those simple things that, you know, we sort of think, oh, yeah, it's not that bad, or even, you know, having to turn somebody every 2 hours, or whatever it is, you know.
Sometimes we just don't think about what that means we're just going through the motions, ticking the boxes, and we're not actually looking at what that means for the person at the other end of it who's experiencing this and living their life like a patient rather than a human being. So
right. Yeah, and palliative care is about quality, living as well as you can for as long as you can.
Yeah.
And so if you take a big picture and take a palliative approach to care, which is what we've been talking about for 15 years, then we need to have a meaningful advanced care plan in place that informs everything that we do. We need to stop at every choice point and say, is this what this person really wants? You know, what do you want? You know, tell us. So beneficial treatments should be effective in prolonging life. Well, I guess so. Yes. Oh, if you're talking about treatments, yes. Yeah. Restoring or maintaining function. I mean, this is all, to me, that's all palliative care. Yeah, and it's all about, you know, relieving symptoms. And again, you know, if you've got, there are certain treatments that are indicated if they're going to relieve suffering. Burdensome treatments, as we've said, would result in more or intolerable pain, psychologically harmful, and really and futile, like not really contributing anything to the person's health in the long run. These are the kind of considerations we need to look at. Pacemaker. Oh, pacemaker's a good one. It's one of my favourites. I can't leave that alone. Really, and encourage your residents to think about pacemaker, and if you put one in, and a bit like the peg tubes as well, if you put one in, is there a point that you're going to take it out again? Because once those things are in, it's pretty hard to make a decision to say take it out. So for me, I know I would accept a pacemaker and then say, you know, if God forbid I developed dementia or something like that, and I would say, take the pacemaker out if I get to 90, because I don't want to be kept alive with this little machine just sort of keeping me going, because it's sort of like we're saying to nature, no, you can't do that. Sorry. Oh, no, this isn't it. Oh, no, you can't have that. No, you can't be here. And you think, what on earth are we going to die of? And the more interventions we put in place, the harder it is for the body to die naturally and easily. And so we're setting up a situation where the person is going to, I don't know whether you understand what I'm saying. Like it's not an easy path then towards death, which is what we're all heading for. And so we always have to take a step back and say, what is this treatment for? I mean, I could tell you a story about an elderly fellow that I was looking after, and he was 89. He'd been in the nursing home a couple of years. He'd had this inevitable slide into dementia, and no one had picked it up. He had no next of kin. He was a confirmed bachelor, scads of money, so plenty of people around him, looking for a bit of handouts, and always, I'll make decisions for him, and he collapsed one day in the nursing home at 89, and was found to be in AF. And the doctor, even against her better judgment, she said, "This is killing me, but I have to send him off because we've got no person to make a decision. We don't have an advanced care plan. And so I can't make this decision for him." And so all she could do was send him off. He got a pacemaker and he lived for another couple of years with declining health, but the pacemaker kept him alive. And so he was falling, and he lived for a couple more years in the nursing home in a demented state. And it just was not, this was an opportunity that his body had perhaps decided, here's my chance. And yet, no, we come along and say, "Oh no, you can't die from that." It's like, what are you going to die from?
Yeah, absolutely. Something that isn't on this list, but might have a repercussion too, is internal pacemakers. I guess that's a bit like, an internal defibrillators. Apologies.
Oh, yes.
I'm looking at the word pacemaker.
I'll fix it now.
Yeah, and internal defibrillators. So internal defibrillators can actually cause distress as well as somebody is entering the end of life, because they will give you a little zap. And actually, I might be under exaggerating that, because I've had a gentleman that I'm looking after recently says that it's quite the shock and can make you feel quite queasy for some time afterwards. That's its purpose. If someone goes into an irregular rhythm, it will give you a shock and try in an attempt to get you back into a rhythm. However, if you are dying and your heart is failing, it will just repeatedly shock you. And it is very unpleasant. So that would actually create an uncomfortable death for somebody, an internal defibrillator.
Yeah. Good point, Sam. Very good point. And again, it just points to, when are you going to, like, if they've got a peg tube, when are you going to stop that? Are you going to, at what point do you decide? So even if they're dying, at what point do you decide, well, we won't be feeding you through the peg tube anymore? It's fraught. It's absolutely fraught.
A really good resource is the LDAC legal toolkit. So on the LDAC website, they have a tab that has the legal toolkit, and it goes into really easy to understand consequences and thought exercises around each of these things, and other things as well, like VAD and stuff. So if you wanted to have a really easy to digest look in more depth at these things and some other things, hop on over to the LDAC website and there'll be a lot of information.
Yeah, I think the course is called End of Life Law for Clinicians. Yeah, is that the one?
There you go. Yeah, that's the one.
Look, I we both strongly encourage you to do that. It's good for your CPD. You tick that off.
Yeah.
And because there are a lot of curly questions in aged care that we bump up against all the time, and I think it's really worthwhile for you to have an understanding of all the different sort of things that you can that can crop up to to trip you up. We need to have a bigger understanding so we can have meaningful conversations with the residents and the families and the other team, the treating team. So the key features of an effective advanced care plan: the nomination of the appointment of the medical treatment decision maker, provision of instructions about a person's beliefs, values and goals and relating to medical treatment. Now, apologise, I didn't alter this slide, but the current advanced care plan, as according to Advanced Care Planning Australia.org.au, for Victoria, is that it has two separate sections. One is the values directive, and that is the person's beliefs, values and goals, and not just relating to medical treatment, but just into life in general. What, as I said, what gets you up out of bed in the morning, what gives you joy, what do you look forward to every day, why, what sort of makes you happy. The other one is the instructional directive. And that is the spot where people can actually refuse certain treatments. So they can say, I don't ever want CPR, or I don't want to be sent off to a larger hospital. You know, I don't want any treatment that can't be given to me here in my little country town. I don't ever want a blood transfusion, or and it's usually about refusing things because consenting, or it could be conditional consent, you know, like a qualified consent. I'll have a blood transfusion if my HB is lower than 6, or I'll have a peg tube, but only for 3 weeks, or you know, whatever it is, or only in this situation. You know, if I only need artificial hydration and nutrition for 2 weeks, then I'm happy to accept that. But if I've had a stroke, then I don't want a peg tube to keep me alive. Those sort of things. Victoria's documentation, I did update this. So that's the Medical Treatment Planning and Decisions Act of 2016. So that's a new act that came in, and that has defined, and I think Victoria is the only state that has this legally binding section in the Values Directive. And so if a doctor decides to override that, they can be charged with assault and be brought before the law. And so if you've put that in your advanced care plan, you know that it's going to be followed, as opposed to nearly all the other states that I think the ACP is more, it's a guide, but it can be overridden. Now, the other part of this this act was the inclusion of a support person, which I think is fantastic. And you can appoint somebody to be your support person. So even when you have capacity and you're capable of making decisions, you can appoint this person to speak for you on your behalf. And they have access then to your medical records, and they can speak to the doctor, and the doctor can speak to them as if they were speaking to you. So you've nominated this person to be equal in the law and that sort of thing for in terms of medical decisions. Who needs to have it? Obviously, the family, you, the hospital, the facility needs one, the GP needs one. It can be written. Well, what if the patient is transferred? Yeah, well, make sure that you make a copy, and also send a copy of the appointment of the medical treatment decision maker too, so that if you're sending someone to hospital, they know who they need to speak to legally, and not just, oh, here's their daughter-in-law's number, sort of thing. Lots of barriers to advanced care planning. Discomfort, definitely, on the part of, the family, the person themselves, culture, the culture we come from. It could be your ethnicity, it could be your family culture. There's a whole lot of different cultures that people belong to. It could be religious. It could just be that people haven't thought about it, or they don't want to get into it. So there's a whole lot of reasons, and I'm sure you've come across them all. So how to implement? Got to raise it. We just have to start talking about it. It's so important. It's going to make everybody's life better. Start talking to the family about it. You can sometimes paint the picture of what can happen if there isn't an ACD in place, or if there aren't directives, or someone hasn't been nominated. Yeah. Communication is really vital. It's absolutely vital to keep communicating with the family, and they are a vital part of this whole process. It's not, we can't do it without them, in my opinion. We've got to make sure that communication is effective, which means that, and that's a whole other education session. And make sure that people understand what you're trying to tell them, and that they grasp the importance of what you're trying to do, and that the that the resident is at the heart of, the whole purpose. It's not so that you can tick a box on the computer program to say, yeah, we did the ACP, it's done now. And to encourage the family and the person to keep on talking about it, and to mention things if something comes up. We go in there again with the talking, and that's why communication and being comfortable with having these conversations is really important, so that it doesn't get built up in this in your head as this really scary thing that you need half an hour to talk about. So your roles and responsibilities, advanced care planning is everyone's business. Have I said that before? And so the ideal would be that all staff know how to conduct an advanced care planning session with the resident and their families, and that we get to identify or pick up on cues that they're saying things like, I don't want to go back to hospital again. Oh, that was awful. And we're hearing that a lot. Even now, COVID has changed the hospital landscape. I mean, it wasn't great before, but it seems like hospitals are really hard places to be in now. Life's just too hard. If I was a dog, they'd shoot me, those kind of things. I don't know why I just can't close my eyes. I'm sure you've all heard these, and they're worthy of documenting and making a note of. When you're talking to your families about this, I'm going to speed it up, hadn't I? Sorry, we're nearly there. They're the kind of questions you can ask. Definitely, what's your understanding of what's happening? We don't want to force people into this space. Sometimes people will, not just the resident, but the families as well. They will walk alongside this as the resident is dying and just flatly refuse or deny that it's happening. And so you can't hit them over the head with it. If that's the way they want to play it, that's how it happens. We can't have this beautiful path for everybody. It just, you work in palliative care long enough, you'll realise that that's how it goes, because people are people and they're all different. These are some of the phrases that you can use when you're talking to the resident and the family. How much do you want to know? It's a fair question. Checking back, if I've heard you right, you seem to be saying, if they're talking about death, is it something you think about often? Those kind of questions. Again, take a screenshot or pause the video. But I think as part of our spiritual care of the person, we need to, and our holistic approach to care, we need to at least open up these discussions for people. It's hard enough watching nurses whiz past the door. If residents don't ever get that feeling that you've got the time to sit and listen to them, then they're never going to open up, and they may not open up to anybody else. They might feel like the family doesn't want to know, they don't want to talk about it because it's too confronting for them. You might be the only person in that, your resident's life that can be a listening ear for them. So just consider that this is such an important role that we as nurses play in this. Definitely review. It needs to be constantly talked about, as I've said before. So there's the overview of advanced care planning. We're nearly there. It's best done when your health status is stable and you're not in a threatening environment, in a non-threatening environment. It's really good to have these discussions often and make it part of a normal sort of day-to-day discussions that you have with them. Take multicultural or just take cultural perspectives into account. And the main thrust is that it increases choice and improves outcomes at the end of life. And who doesn't want that? Now, as I said, they may not choose to take part. We just try and do the best we can, but at least if we've given people plenty of opportunity to take this up and actually create a plan, then we've done our job. It's interactive communication is the main principle. And there's where you can go to. So you can go to the Office of the Public Advocate. You can go to advancedcareplanning.org.au and follow the list. And there's you can go to health.vic.gov as well. There's stuff about advanced care planning there as well. And
sorry, Rose, the videos and the brochures and the literature on the advanced care planning.org.au website are very user friendly. And so if you were to want to take part in Advanced Care Planning Week, for example, which I think is every September?
March.
Oh my gosh. Well, I was absolutely out. Well, there you go. Well, it's a lot closer to March than it is September. So that's good. I don't know where I got September from. Might be Palliative Care Week. There you go. So, and then, did I get that wrong as well?
Yeah, it's in May. Hospice days in the beginning of October. Anyway,
that's okay.
Yeah.
So good literature.
Advancedcareplanning.org.au also have a little course that you can do. I think, pretty sure you can access that as well. So there's courses for health professionals. And here's my final slide that I think it's a bit of fun. It's an oldie but a goodie. It does make you think about being on our phones and developing the extra vertebrae in the back of our necks. Yeah, so thank you very much for hanging in with us. It's been a big talk video, but I think it's all worthwhile. And of course, Sam and I are always happy to answer questions. Just shoot us an email if you want to know more, or if you want someone to come and talk to you directly at your facility. But yeah, encourage people to have a look at this video. It'll be up on our YouTube site. Sam, anything else to say?
No, that was a very key look over advanced care planning.
Okay, well, I'll stop the share and I will bid you all a good night.
Thank you. Thanks, Rose. Thanks, Sam.